Hello, everybody. My name is Roxanne from RBC Consultants. Welcome to another Skin Chat. Today, we're going to be talking about a global perspective on the treatment and maintenance of mature skin using Gentl cleansers and moisturizers. Our international speakers today are Dr. Andrew Alexis, who is board-certified dermatologist in New York, Dr. Olga Barrios, who Centro de Dermatologia, Porto Alegre in Brazil, and Dr. Peter Bjerring, who is Department of Dermatology, Aalborg University Hospital in Aalborg, Denmark. We'd like to thank our sponsors, CeraVe, for making this educational event possible. Before we begin, a couple of logistics tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your questions using the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will be emailed to you within 1 to 2 days. We'd greatly appreciate it if you could fill it in and send it back to us. Within 1 to 2 days of the webinar, a certificate of attendance and the recording of this webinar will be sent to you. Again, please submit your questions using the question chat pane on the right-hand side of your screen. And I wrote a little note there so you can see exactly where you need to type in your questions. So without further ado, I am going to pass the floor virtually to Dr. Andrew Alexis.
Well, thank you, Roxanne, for that introduction. And it really is a pleasure to be here with two of my esteemed international colleagues to discuss mature skin cirrhosis, an issue that I'm sure all of us tuning in from around the world can appreciate, seeing this day in, day out with our patients. I'm going to start with a brief introduction, a broad introduction to the subject matter, and then my fellow speakers will take a deeper dive into some of the specific physiologic aspects of mature skin cirrhosis, as well as some therapeutic interventions that can be very helpful. So when we look at the global population, we see practically in every country in the world, every region of the world, that there's this shift in the population, shift in the demographics towards a more aged population. So we're seeing that with increased life expectancy around the world, we're seeing a greater proportion of the global population being over the age of 65, for example. In fact, some interesting statistics from the World Health Organization say that the number of persons aged 80 years or older is expected to triple between 2020 and 2050 to reach 426 million. And there's some interesting populations that I'm sure many of us have heard about in the news media and in studies. There's some interesting populations around the world that have a tendency to have a much longer life expectancy than the average. And one such community is in Okinawa, Japan, Sardinia, Italy as well, and other places listed on the right. And I do intend to visit all of these places and maybe one day retire in one of them. Seems like they're doing something right. So with the privilege of maturing and aging and living more and more decades, it does come with some changes to the skin that we can all appreciate as dermatologists. These include gradual thinning of the epidermis, a slower keratinocyte turnover, reduced stratum corneum lipid content, including ceramides, which we'll certainly be talking about today. There's a decline in natural moisturizing factors, loss of that acid mantle, so loss of the acidification of the stratum corneum, delayed wound healing, increased corneocyte retention, which manifests as scaling, just the diagnosis of xerosis, which we're talking about today, associated itching, and downstream increased susceptibility to pathogens, including bacterial, viral, and fungal infections. So these are the downsides that we have to sort of actively manage for our patients as dermatologists to minimize these sequelae. So when we look at how prevalent xerosis is in our patients over a certain age. We see multiple studies that demonstrate this very high prevalence. One frequently quoted study states that mature skin-related xerosis affects over 50% of individuals 65 years of age and older. In a cross-sectional study from Germany, where of more advanced age, 83.6 was the mean age, and these were care-dependent patients, the prevalence was as high as 99.1%. And when we think about the etiologies of age-related xerosis, beyond just the physiologic changes that we discussed about what happens as the skin matures, there's of course a whole host of extrinsic factors that can contribute to this. Medical conditions as well, medications, all can contribute to itching and xerosis that we see in this population. So in addition to just pure dry skin, we can often see associated inflammatory changes in the form of dermatitis, asteatotic dermatitis or eczema craquelé, this sort of dry, parched riverbed appearance of the skin, this very classic morphology of eczema craquelé. So in addition to moisturization in this situation, of course, we'll often have to turn to prescription topical corticosteroids to calm down this dermatitis, this inflammation. Even without inflammation, pruritus is a common symptom in the context of dry skin or xerosis. So we can all relate to our patients who come in complaining of very itchy dry skin, and on examination we see xerosis, but we might not see an actual dermatitis. There are multiple studies that show this high prevalence of pruritus, and this really contributes to the burden of mature skin xerosis. So we recently convened a group of international dermatologist experts to discuss the impact of mature skin cirrhosis and the importance of promoting a healthy barrier. And this resulted in a poster that was presented at the South Beach Symposium in Miami, Florida, earlier this year in February. And out of this came 5 consensus statements that we'll be going over during the program. This same work is leading into a publication which is currently in development, soon to be submitted to a peer-reviewed journal, and where we have the objective of increasing our understanding of the multiple aspects of mature skin xerosis, and discuss some of the data that supports using skincare to restore a healthy skin barrier to reduce mature skin cirrhosis and its sequelae. So briefly about our literature review that was necessary for the poster and the soon to be submitted publication. We used various search engines, including PubMed and Google Scholar, with the search terms shown here, including terms like mature skin cirrhosis and other terms that speak to barrier dysfunction that would be relevant in this population. And doing so, we identified 93 initially publications, and then excluded 58 of them not meeting criteria, and ultimately we're left with the number of publications that you see at the bottom of this algorithm, and worked with those to develop our consensus statements using a modified Delphi approach. So we, in addition to the literature, we had this expert consensus group convened, and using a modified Delphi process, arrived at these 5 consensus statements, which we'll go through. The participants in this group included myself and Professor Olga Barrios, who you're going to hear from, Professor Peter Bering, who you're also going to hear from Denmark and South America, and from Europe we have Professor Fleur and Peter Foley from Australia, Michael Gold from the United States, and we had representation from Kenya, the East African perspective, as well as in China from Professor Zhang. So this is a little snapshot of who participated. So we came together and we came up with these key statements, the first of which being that aging beyond 50 causes fundamental changes in the skin with significant and widespread dermatological implications such as xerosis and related pruritus. And that was an easy one to agree on. In fact, there's lots of literature just like this paper here, which is based on a large prospective cross-sectional study based on the Rotterdam study. And they looked at, and these were dermatologists examined patients who were diagnosed with either generalized dry skin or localized dry skin. And in this group of over 5,000 participants, 60% had dry skin. The average age was 70, although the range was 51 to 101. And a fifth of this group had generalized dry skin. So really speaking to that very high prevalence in this age group. The second statement speaks to the quality of life impact of xerosis, mature skin cirrhosis. And in addition to the quality of life impact, there are also downstream sequelae such as secondary infections, ulcerations, chronic wounds. So that impaired skin barrier not only contributes to the dryness and the itching that we see, but also some significant downstream consequences such as entry of pathogens, irritants, and delayed wound healing as well. So this is the basis of the second statement. There's a number of studies that support the quality of life impact of mature skin cirrhosis. This is one recent one that I'll highlight. This is a paper that's from Hamburg that looked at, I like this because they had a comparison group where they looked at patients with xerosis cutis and compared it to a control group without xerosis cutis. And what they found was lower health-related quality of life in the xerosis patients versus the non-xerosis patients, but also some additional findings which are interesting, including more dysmorphic concerns using an instrument to measure that, and higher general anxiety than individuals without xerosis. The prevalence of atopic dermatitis, if they had atopic dermatitis associated with their condition, xerosis cutis, the quality of life impact was even greater. So with that background, it's my pleasure to turn the virtual podium over to my colleague, Professor Olga Barrios from Brazil.
Thank you very much, Dr. Alexis. It's a great pleasure to be here. So can we put the polling question?
There you go. One polling question.
Okay. So what factors contribute to skin cirrhosis? A, intrinsic age-related changes of the skin barrier. B, systemic condition. C, oral medication, overuse of heaters or air conditioners, or all of above. So we will for the answers. Great. All of above factors, and we are going to discuss in a little bit of detail on the next presentation. So our statement 3 was the etiology of cirrhosis depends on several genetic and environmental mechanisms affecting keratinization and lipid content in the stratum corneum, including intrinsic age-related changes, use of diuretics and other oral medication, systemic conditions such as hypothyroidism, and overuse of heaters or air conditioners. So how does our barrier function change with age? This is a glance overview of the difference of the younger skin and the older skin. And there is three important changes. First, the epidermal atrophy. Second, the smoothing of the epidermal dermal function. And third, the epidermal atrophy with disorganization and loss of collagen fibers, reduced vascular tissue, and alteration on nerve fibers. We're going to show 6 key points regarding the aging of the skin barriers. Keratinocyte renewal slows down and apoptosis increases. Skin barrier dysfunction may lead to increased water loss. The number and function of the sebaceous glands decrease, leading to cirrhosis. Cirrhosis results in increased vulnerability of the skin and marked pruritus. There is also degeneration of skin innervation with imbalance of heat and cold tolerance deteriorates. And pruritus may cause scratching, leading to secondary lesions as excoriation, erosion, and even chronic wounds that increase the risk of skin or even systemic infections. So this slide is very important to help us to understand how aging-associated change in epidermal function affect the skin barrier. So there is a decrease in stratum corneum lipids, mainly cholesterol, decrease of differentiation related proteins, decrease of NHA1 that is important, is a protein very important for maintaining the balance of the skin pH, decrease of the enzyme, phospholipid enzyme 2, important for the metabolism of the phospholipids. All these alterations leads to decreased permeability of the barrier. On the other hand, decrease of sebum, filaggrin, NH1, and phospholipase enzymes increase the skin pH. Even a small alteration of the skin pH has a great consequence in leading to cutaneous inflammation, and they also decrease the production of the stratum corneum lipids. The decrease of aquaporin 3, that is important membrane for the transportation of water and glycerin, associated with decrease of sebum, lipids, and filaggrin, leads to decrease of the stratum corneum hydration. So these three conditions increase the cutaneous inflammation associated with immunosenescence, with increase of levels of cytokines, mainly interleukin-1 beta and 6, and also chemokines. And if there is also association with systemic disease, they will cause a great impact in the function of the stratum corneum barrier. On the other hand, we have pruritus, as Dr. Alexis mentioned, is a very important condition and is very frequently associated with mature psoriasis. So the cutaneous inflammation leads to pruritus, and pruritus with the scratching opens allows the enter of irritant or allergen products that also decrease more the permeability of the barrier. So all these changes leads to a thinning of the epidermis, slower of the keratinocyte turnover, reduce of the stratum corneum lipid content, loss of the acidification, delay in wound healing, increased corneocyte rotation, cirrhosis, and even increased susceptibility to bacteria, viral, and fungal infections. Also, there is a decline in natural moisturizing factors, mainly the free amino acids, glycerol, and hyaluronic acid. The stratum corneum lipids decrease with age, and ceramide, that is one of the most important lipids present in the stratum corneum, decrease with age. Here, for example, we have the content of ceramide 1 linolate decreased by age of 70, almost half. And this is very relevant causing psoriasis. Studies have shown that there is a reduction at least 30% in total lipid content related to the ionic skin. And this is due to the decrease of the epidermal lipid synthesis. And this is in normal conditions of when the barrier function was affected. The tapestry feeds on the face here shows decrease in fatty acids, ceramides, and especially cholesterol. And very important, this is from age 41. So besides the aging-related factors that decrease the hydration of the stratum corneum, there is other factors that contribute to psoriasis, intrinsic factors and extrinsic. Dermatologic disease, mainly atopic dermatitis, allergic and irritant contact dermatitis, psoriasis, fungal and bacterial infection, scabies. Scabies is very important in elderly patients who live in nursing homes, and this severe pruritus and cirrhosis. Lymphoproliferative disease, internal disease, chronic kidney disease, pathopathies, very important diabetes mellitus and hypothyroidism. Chronic inflammatory bowel disease, especially the gluten sensitivity enteropathy, rheumatic disease, especially Sjögren's syndrome, viral infection, special conditions during the individual's life, such as menopause, andropause, and pregnancy, and lympho and myeloproliferative disorders. Psychiatric disorders are very important, especially in those with obsessive skin cleaning habits, alcohol, drug abuse, and depression. Elderly patients have also decrease in fluid intake and maybe some nutrients, so hypovitaminous deficiencies and zinc and iron deficiencies can contribute to the cirrhosis. As we get older, so we will have more comorbidities and a polypharmacy. So there is a huge list of medication that can produce cirrhosis. The most relevant are diuretics, lipid-lowering agents, calcium antagonists, cytostatic agents, and nowadays the immunobiologics. And also two important things from the exposomes that can influence in cirrhosis are the air pollution and UV exposure. So there's other things important to consider with cirrhosis. Skin properties and conditions vary with body size. We know that lower legs and heels are the places that are frequently more severe with the cirrhosis, and also be influenced by skin type, ethnicity, gender, lifestyle, environmental, and it's very important, access to care. Data and racial and ethnic difference in the burial structure were presented and were observed difference among Black, White, Asian, and Indigenous populations. So some studies suggest that there is a variation in ceramide content and stratum corneal structure. The difference between racial and ethnic populations may contribute to variation in the prevalence, especially in the severity of atopic dermatitis, cirrhosis, and pruritus condition. And also very important are the cultural norms or perception of the skin and the impact and the choice of the skincare products. So here in this study shows the difference observed in epidermal lipids among different individuals. African American, they show a significantly fewer ceramides content in the stratum corneum compared to Caucasian or East Indians. This is a picture of a patient of skin color with severe cirrhosis, scaling, fissuring, and here showing hypo and hyperpigmented lesions. Atopic dermatitis cirrhosis patients with richly pigmented skin have a high risk of developing post-inflammatory depigmentation. And it can last for years, and even if the cases are not severe, the depigmentation can subside, but chronic escoriation may result in permanent depigmentation. And this is a sequela that highly impacts the quality of life of those patients. So data from atopic dermatitis patients of Asian and African descent living in the US indicate that pruritus may be more frequent and severe. Also, there is a higher incidence of pruritus nodularis and atopic dermatitis in Black skin color patients. Some data shows that increase in transepidermal white loss and decrease on the ceramide content in Black skin can contribute to pruritus and related conditions. Also, variation in composition on the skin of the Black skin can be important for those patients with intense and chronic pruritus. So in summary, mature cirrhosis is common, is multifactorial, and its factors may include intrinsic area-related change, use of systemic medications such as diuretics, systemic conditions such as hypothyroidism, overuse of heaters or air conditioning. The studies have shown that there is more than 30% reduction in total lipid content compared to young skin, and this is due to the reduced epidermal lipid synthesis. There is a difference between racial and ethnic population that may also contribute to variation in the prevalence and severity of patients with atopic dermatitis, cirrhosis, and pruritus. And very important are the environmental issues and disparity in access to care to facilitate the skin facilities. So there is a summary, and thank you very much. This is now a pleasure to introduce Dr. Bering.
Thank you very much. I will take over. So first of all, we have a polling question to start with in this presentation. And the reason for this is that we now have a new multivesicular emulsion, which is a quite new development. And it's interesting to see how many of you actually know what is the important thing of this emulsion. So it can either, please select one of these. Does it make the cream very easy to apply? Is the optical scattering giving it a pearly white appearance? Do the many layers of the multivesicular emulsion provide a slow release effect? Do the multivesicular emulsion have a high content of ceramides? Or will the multivesicular emulsion increase the shelf life of the products? Please vote and let's see what we get. Right. It's totally, the many layers of the multivesicular emulsion provide a slow release effect. That is correct. That is the most important. But the others who are actually have voted on the easy to apply and high content of ceramide, that's also correct. But the most striking property of this is the slow release effect. And I will talk a little bit more about that later on. So we are now going to again to address the patient's need with skincare using cleansers and moisturizers. And our statement number 4 out of the 5 statements is that Gentl cleansers and moisturizers, which can help promote a healthy skin barrier and reduce pruritus, are underused in mature cirrhosis and may be impacted by cultural factors. And here we see the well-known model of the skin barrier, the stratum corneum and epidermis, where we can see the mortar and brick model here, where we have an intact skin which has a low water evaporation and a low penetration of irritants and allergens from the outside, while the defective skin barrier is open, meaning that we have a lot of evaporation making it dry, and we have a possibility for allergens and irritants to get to the deeper skin layers. And that's all about the mortar in the wall, meaning the lipid composition between the cells. And a normal good moisturizer will contain 3 ingredients: emollients to smooth, which could be glycerin, oil, or butters; humectants to hydrate, which could be urea or natural moisturizing factors; and it would be also containing a light occlusive to trap the moisture at the top so that these parts actually get moisturized. It could be silicones or petrolatum, which would give a cover up here. But moisturizers can be optimized further by the addition of physiological lipids to restore the skin barrier function. And these are ceramide, cholesterol, free fatty acids. There are some lifestyle factors that can influence cirrhosis and pruritus. First of all, cold, low humidity, dry indoor heat, and extended exposure to sunlight. We know these occupational factors and hobbies where we see problems with hairdressers, construction and metal workers, nurses, housekeepers, and also habits, skin cleaning and cleansing, and frequently taking long hot showers and baths, or use the old-fashioned alkaline soaps and cleansing agents. And there are some measures to be used to reduce the risk of mature cirrhosis: taking shorter baths, avoid wool, avoid spicy foods, large quantity of hot drinks or alcohol, avoid very hot or very cold climates or temperature variation, intense sun exposure, and also lifestyle like stress. Our statement number 4 is that the unmet need for skincare in mature cirrhosis may be addressed with ceramide-containing cleansers and moisturizers, and that is supported by clinical data, and I'm now going to show you some of these clinical data that we do have. But first of all, again, a standard good moisturizer will contain occlusive agents, humectants, and emollients, but can be improved further by adding ceramides and adding this new multivesicular emulsion technology that I just talked about before. And that multivesicular emulsion is actually to make fat droplets with multiple layers, which open up one by one, giving a very slow release effect. That can be seen on this graph here, where we see the skin hydration after this multivesicular emulsion, either as a cream or a lotion, and they are much, much better than the paraffin-based emollients, 3 different competitors. And after one single application, it even is significantly better than the others 1 day after a single application. That's actually fantastic. And in this study here, it's an investigator blind controlled study on 49 women from 30 to 65 years with dry or very dry skin. And we could see that the improvement from baseline in skin dryness, skin roughness, desquamation, and erythema dropped 79% after application for 28 days. And if we again wait 48 hours after the last application, it still has significant effect compared to the before. So it's even better than just after stopping. So it has a very, very prolonged effect using these special delivery systems here. Some results here, an average result before with some desquamation, dry skin, eczema craquelé. 4 weeks after treatment, much better. And even 48 hours after the last application, we see a better effect. This is a very good example here. Again, fantastic skin texture here, 48 hours after the last application. This double-blind study here looks at eczema-prone skin. And in eczema-prone skin, we can actually see that the skin hydration measured by capacitance is better in 3 age groups, up to 39, up to 59, and 60 plus. Much better than the petrolatum-based moisturizers in all 3 groups, age groups. And the same goes for stratum corneum with an optical, measured by an optical way. We can see a better moisturization with the ceramide containing cream compared to the paraffin-based emollient. And again, here, after tape stripping, meaning mechanical damage to the skin, we do get less water evaporation in the ceramide containing treated areas compared to the paraffin treated areas. And again here, also again, tape stripping resulted in less loss of protein, meaning that the stratum corneum is much stronger using the ceramide containing moisturizers. And this is a challenge with soap. This is 24 hours of a patch test with 1% sodium lauryl sulfate, which is a standard soap test that would normally produce erythema, which it also did in the paraffin based moisturizers here, while the ceramide containing had less redness as judged by visual evaluation. This is objective measures of redness, again, lower redness scores in the ceramide cream. And this is water loss through the skin, higher water loss in the paraffin-based emollient compared to the ceramide cream. This is a very elegant method. This is Fourier transform infrared spectroscopy, and using that we can evaluate the integrity of the lipid membranes. And this, what we can see here, that if it moves this way, we get a less wavelength here. It's 2865 and it's 2835 here. It goes the opposite way than normal. But again, you can see we get a better lipid composition with the ceramide cream compared to the paraffin-based creams. In this clinical study here of patients of 70 years plus, we can see they actually use in average 2.4 drugs, and many of these drugs may impact on the skin dryness and pruritus. And here we can see that the level of severity of roughness decreases by 82% after 28 days. And again here, with the discomfort due to skin dryness and fissures, all reduced very, very significantly. And also we can see the same here, roughness, discomfort, and fissures. The least problems are magnified here at week 4 for all 3 parameters, meaning that the patients get less problems. Here we can see before and after with the eczema craquelé again being treated completely. And again, quality of life, this is the impact of this, meaning that we can see 77% of the subjects no longer felt embarrassed or awkward about their skin, and 90% no longer felt that their dry skin impacted their social or leisure activities, and 93% of the patients no longer felt their dry skin limited their daily activities. If you want to study more, there are some good references here where you can actually check which effects we see on mature cirrhosis here with different interventions. So in summary, currently Gentl cleansers and moisturizers are underused in mature cirrhosis, and challenges include the lack of awareness of maintaining a healthy skin barrier, a multitude of health issues, polypharmacy, variation in skin types and skin tones, culture, climate, and barrier to access. And clinical studies supporting skincare for mature cirrhosis are mostly small and not always specifically aimed on mature skin cirrhosis. Skincare is frequently lacking or overlooked as part of skin treatment for this population to reduce pruritus and to promote a healthy skin barrier. It is an unmet need that can be addressed with ceramide-containing cleansers and moisturizers. Thank you very much.
So please submit your questions using the question chat pane on the right-hand side of your screen. And if you remember any questions afterwards, you can always submit it to us, info@rbcconsultants.com, and we can forward it to our panel. Again, we'd like to thank our sponsor, CeraVe, for making this educational event possible. So we do have a couple of questions from the audience. The first question is, are there differences of the skin barrier between races and ethnicities important for the severity of xerosis? So if our panel can come back on, Dr. Alexis and Dr. Bering, there you go. So who would like to start by answering this question?
Well, I will start. So there is some studies that suggest that there is a difference between races, and especially in patients of skin colors, regarding the decrease of lipid contents, especially ceramides. And there is a paper that was published by Dr. Alexis, one of the authors, in 2022, addressing an insight of patient skin color and atopic dermatitis and improve with the skincare. So we can see that also the pruritus will be more severe in patients of skin color for decrease of the lipids and also for these mast cells alterations.
I think that was a great answer. I'll just add to that and maybe repeat even some aspects of what you said there, Dr. Barrios, that there are some studies that do compare racial ethnic populations with respect to skin barrier characteristics and how they might relate to the prevalence of xerosis and atopic dermatitis. So there are some studies that show reduced ceramide content in patients who self-identify as Black or African American, depending on the study referenced. We think that this is might be one of the factors that contributes to the observation that xerosis appears to be more prevalent and often more severe in our patients from those backgrounds. The reality is, though, we do need more studies that better define these populations and are larger so that we can make them more generalizable to the general community. But this is some of the data that we have.
Another question, what environmental factors are relevant for mature skin-related xerosis?
I can answer that. I think we have seen studies that are looking at climate changes. We actually see that the climate changes, we get more extreme weather, which means that the skin is exposed to a more cold and hot environment and shift in temperatures, which seems to affect the skin as well. Also, ultraviolet radiation changes. We do have the ozone holes, which also impact the amount of ultraviolet light that the skin receives. And again, that seems to be important for the mature xerosis.
Yeah, I think that is especially in patients that are 80 years from the balance of the heat is very important because those patients feel cold all the time. So they usually use heaters. They take long and very hot baths. They use a lot of clothes on, so this will increase the perspiration. So those patients, and many of them live by themselves, so they don't have any irritation. So maybe we need to be more proactive in those patients, teaching in a regular practice, daily practice, how to change these habits, because they have a huge impact on the quality of life of those patients.
And you know, that does bring up another aspect to when thinking about xerosis of the skin across global populations. There are all sorts of variations in cultural norms with respect to bathing habits, skin moisturization habits, preferred products to use, which might be relevant to us as dermatologists when we treat patients with xerosis. We can see some communities where it might be customary to take very long hot showers and use maybe products, cleansers with harsh surfactants that contribute to more dryness and disruption of the barrier. And then there may be cultures who have the opposite in terms of their normal, customary routine skincare. So I think the cultural and the environmental factors all are important to recognize as well.
I also think that economical considerations are important here, because there are many countries where a great deal of the population cannot afford to use moisturizers as they are now.
Yeah.
Another question to our faculty, do you support topical estriol in a proper base for postmenopausal skin?
Well, I think that this is an evaluation of an individual case. There is a huge movement of hormone replacement in menopause. There is some data that say, you do as an individual on all your skin whole evaluation, you can use the hormone replacement. But on the other hand, there is a movement that everyone in pre or postmenopausal stage to have a replaced hormone. And I think that it has to be each case evaluated in conjunction with the gynecologist, with the internal medicine.
I think we see a difficulty between doctors in evaluating this, and many doctors seem to be afraid of using topical estrogens for skin conditions. But apparently, the population are not that scared, because I just saw this trend on TikTok where people actually are using vaginal creams for facial treatments to get the estrogens without being consulted by a dermatologist.
What distinguishes ceramides from ordinary lipids?
I can tell you that ceramides are actually a special component that is not unique for human skin, but is essential for human skin. And it's not a normal composition of creams, because normal creams are actually made by plant-derived fats or butters with an emulsifier making small droplets, and then water. Basically, these three things. But with this, we introduce the natural fats, the type of fats that the skin would make itself, and which are often washed out or produced in smaller quantities in mature cirrhosis.
Is there any specific, on that same trend of thought, is there any specific percentage amount of ceramides in treating cirrhosis effectively? And additionally, is there any other ingredients that can help in the treatment?
I don't, should I? I think that there are three essential ceramides present in the skin, and then we have the triglycerides and we have the cholesterol. And these components are all important for building the correct and the natural skin barrier. So these are important. The composition, the exact composition, the percentages and so forth, that might vary, and it might be different in a lotion and in a cream.
Now, is there any guideline or tips in usage between ceramide moisturizers and corticosteroids?
I'm not sure about that.
The ceramides are very important, especially in the formulation that CeraVe has developed. The three ceramides and the vehicle. So the use is to control the cirrhosis and prevent the cirrhosis. If you have an inflammation, severe inflammation for cirrhosis, so you have to use topical corticosteroids. But that's the point. If you prevent the cirrhosis, you will need less use of topical corticosteroids, and that's what's the point. Prevention. It does with bath, taking all the cares specifically for the baths and the daily hydration. So, and there is no just a crisis, so I'm going to use the ceramide and I'm going to use the topical steroids. Probably the need to use these topical steroids will decrease considerably over the time with the regular use of the moisturizer.
I have many patients now with eczema-prone skin who normally would use topical steroids, which they tell me that they can reduce the use of that because they now use the natural fats and ceramides, which are included in these products here.
Indeed, I think that's such an important point, that when we're faced with a patient who might require a topical corticosteroid for a eczematous disorder, whether it's nummular eczema, atopic dermatitis, etc., the corticosteroids, we use them short term to treat the lesional skin, but without the ongoing use of good skin care that is designed to protect that skin barrier and replenish the loss of natural skin lipids, then that patient's going to continue going back to that same topical corticosteroid, which is something that we always are trying to avoid. So completely agree with the role, the adjunctive role, and not just adjunct, but role as an adjunct and also as a maintenance therapy to prevent frequent recurring use of the topical corticosteroid. So the two go together.
Can statin therapy decrease cholesterol in the skin? What should be done to mitigate?
So patients on statins, yeah, I think this is a great example of a patient population that where one should take special care to ensure that they are caring for their skin in an appropriate manner to minimize further cirrhosis that they are susceptible to while being on a statin. So this is where a ceramide containing cream can be very, very useful. In addition, using a skin cleanser that does not have a harsh surfactant and also has moisturizing ingredients. So moving away from traditional soaps to more sophisticated skin cleansers with pH that's more physiologic, gentler surfactants, additional ingredients that are hydrating and barrier friendly, if you will.
This is very important because sometimes doctors just think that moisturizing, but the bathing habits are very important. So the use of the cleansers are, some patients even just have a barrier condition of the skin just with the adequate cleansing products. And the soap, the alkaline soaps, again, there is a huge use for these soaps with perfumes, with essence, with color that increase the risk of irritant and contact dermatitis.
Yeah.
This is the popular question. What should be applied first, steroid or moisturizer?
I wonder if you're going to agree. Maybe we've got three different opinions. Let's see. Who wants to go first?
I would say moisturizer. And even when I use corticosteroid, I put first the moisturizer, especially because I live in in south of Brazil. There is a cold and humid weather. So patient, if you just say, well, you apply just the steroid, they will forget the moisturizer. Right? Just both have to be used during the day.
I agree, moisturizers first and steroids afterwards, because they remember the steroids, not the moisturizers.
Yeah.
Well, it looks like it's unanimous. I also recommend moisturizer first.
I think that's a first, a unanimous answer. And then in terms of the sustained release, how long does this effect last?
In the studies I presented, you could see an effect 48 hours after discontinuing the treatment. You still have a very, very fine barrier function, and it's after 1 day, it's statistically significant different from moisturizers based on paraffin. So there is a very, very, very distinct slow release effect of this new formulation method.
Yeah, I think that this one of the great advantage of the CeraVe is the multivesicular, that you have a slow release and long action.
Yeah.
So sometimes I don't tell the patient that it would last for 40 hours because he's going to skip 1 day or maybe 2 and they forget. But I'm sure that if the patient forgets 1 application, he will be still hydrated.
Yeah.
Well, that's all the time we have together today. We'd like to thank our international panel for a wonderfully insightful presentation, and we'd like to thank you all for joining us. Have a great remainder of your day. Bye, everybody.
Bye.
Thank
Bye.
you.
Thank you
Thank
very
you.
much.
Bye-bye.
Bye.